Okay, what I'm going to do is go through some of the questions that were most missed and show you how you need to start looking at the stem and then the choices and start eliminating those. Because some of them you should have been able to eliminate very easily. And you're going to have to do this on your national exam because there's going to be things that we may not have talked about. But again, you should be able to look at your choices and eliminate two right off the bat, and then you have two that you've got to decide on. Okay, the first question here, we're looking at the branches of the sciatic nerve, which of course has intervention to the extremity, the foot flexors. Okay, the pudendal and the peroneal nerve. Pudendal, we talked about that when we were talking about positioning on the fracture table with the peroneal post. So you should have been able to mark that one out. And then the peroneal nerve, when we're talking about positioning and using the candy cane stirrups, the lateral aspect where the knee, if it's touching the stirrup, then you can injure the peroneal nerve. And so that's going to leave you with either the tibial nerve or the fibular nerve. And the tibial nerve is more posterior, and you can see here from this diagram, this is the fibular nerve here, and how it's more of a lateral aspect down to the foot. The next one is, I just had papaverin listed twice. Again, I do want you to be able to eliminate here. So we're looking at the dissection of the IMA and using the injection solution to help reduce muscle spasms. Now, we know that bacitracin is a antibiotic. It's a topical antibiotic. We used to use it a lot. Orthopedic cases have bacitracin irrigation on our back table. Lidocaine is more of a local, it ends in cane, local anesthetic. So that leaves you with papaverin. And of course, you wouldn't be injecting any bacitracin into a vessel. But as I said, this was, I think, the most missed it because I had papaverin listed twice. Cardiac arrhythmias, ventricular origin, treated with, let's see what, the most was sodium bicarbonate. Sodium bicarbonate is baking soda. Now we do use that during a crisis situation and when the patient is in cardiac arrest and with metabolic acidosis. So we do give the patient sodium bicarbonate at this time. But we're talking about a cardiac arrhythmias. Again, where there's no rhythm in, maybe beating too fast, beating too slow. Lasix, again, that's a diuretic, mainly congestive heart failure. So that's going to leave us with atropine and lidocaine. Excuse me. Now, atropine is used, excuse me, to treat bradycardia. But here we're not identifying any particular type of arrhythmia. Now, don't get atropine confused with adrenaline. Adrenaline is your epinephrine, which will, of course, cause the heart to beat faster. But we give them lidocaine. The section that least affected. Now, normally, Crohn's disease is, of course, an inflammation of the digestive tract, and it can occur in any portion, but it's mostly the small intestines and the large intestines. So here we've got the duodenum, the ascending colon, and the transverse colon, which are all parts, but the rectum you can see here, that's the lower distal part of the colon. But again, Crohn's is mostly in, and you can see how it identifies these little dark areas here but mainly small and large, and it wouldn't be so much in the rectum. Meiotic drugs, know your difference between your meiotic and your mydriatic. If you will notice that meiotic has T, and if you can remember, that means tiny or little, and mydriatic has the D in it, which means to dilate. And I know a lot of you may not be working with eyes, but that doesn't mean that there won't be some eye medication on your exam. So you do want to look over that. So what we're looking at here is what's going to constrict. All these actually dilates. Okay. Now don't get scopolamine. That's also a drug that we can give for post-op nausea and vomiting. But pilocarpine, it will constrict, and sometimes your surgeon will, especially if once he gets the lens, the IOL intraocular lens into the capsule, he may have the circulating nurse to drop some drops on the eye to sort of bring it down and help hold it in there. But your atropine, this is one that they're going to be over in the holding area, and they're going to be giving a round of drops to dilate. One of those are going to be your atropine drops. So again, remember T, this is the one that's going to constrict or make it tiny or little. Mydriatics, these are the ones that's going to be, remember D for dilate, and they're going to make it larger. Clestotomia, the first thing you should ask yourself, what is that? Of course, it's a benign tumor. And thinking back to your ENT when you're scheduled for a tympanomastoidectomy, so that would be the mastoid bone. We certainly want to go into the cranial area, the maxillary sinuses. You wouldn't have a clestotomia there, or you wouldn't have one in your eustachian tube. But this is using your burr. You can see one here, clestotomia, and as I said, that's mostly when they use your burr to do away with the clestotomia. A broad spectrum bactericidal. Now, when you're looking at these antibiotics and stuff, you want to think about what they're using in the OR. And that's true for your SFA exam. They're not going to be asking you something that's mainly used maybe in the children's clinic with pediatric patients. So we're looking at a broad spectrum. That means gram-negative and gram-positive. Tetracycline is an antibiotic, but how often do you hear of tetracycline used in the OR? Same thing with your sulfa drugs. They're used to treat infection, and your glycosides. This is a broad spectrum, but it's normally used only for children. Okay, and that's going to leave us with we do use a lot of Kefsol because it is a broad spectrum, and it will treat a number of different types of bacterial infection. So again, think about your medication that's mostly used in the OR and start eliminating those that you don't really hear a lot about. Which nerve is presented to during a parotidectomy? Now, I think some of you just didn't know where the parotid gland was. Remember, it's right in front of the ear, right here. Excuse me, the accessory nerve, which is cranial nerve 11, your vagus, which is cranial nerve 10, and your hypoglossal, glossal is tongue, cranial nerve 12. But all these will eventually travel down the neck, okay? So maybe if we were doing your thyroid, or your parathyroid, but here we're looking at the parotid, removing the parotid gland. And it's going to be the facial nerve. And you can see sort of how it branches out here, cranial nerve number 7. So that's the facial. A common autologous donor site for a free flap for replacing the jaw. Of course, autologous meaning auto means coming from the self. Okay. Now the iliac crest, we would mainly use that if we're doing orthopedic cases and we want to take maybe a bone graft. Um, Rib could be used, but think about when we're looking at this, if we take a rib, think about how invasive that's going to be for the patient, okay? Um, so that's going to leave us with either the fibula or the tibia. Now, if you look here at the tibia, look how large that bone is and think about the size of your jawbone, okay? Another thing that you should think about is what is the primary weight-bearing bone in our leg, okay? It's going to be the tibia. So if we take that tibia, if we take a portion of the tibia, then we may have to have that patient, you know, limit weight bearing for some time. So the fibula, which is the fine bone, I remember F for the fine bone, would be more easier to use. And again, the patient is going to recover very quickly from this rather than doing a rib. Or as I said, the iliac crest, you're not going to be able to get that type of bone that's that's going to be used for your jawbone. If we were doing orthopedic cases and we need a bone graft or something like that with orthopedic, then of course the iliac crest would be a great place to get that graft. Which of the following nerves could be injured during a lateral lower leg fasciotomy? If you remember, a fasciotomy is mostly done for compartmental syndrome. If you think about your sciatic nerve, most of that is, people that have back problems. They've got maybe a ruptured disc or pinched nerve, pinched sciatic nerve that's running down. So that's more of the posterior part. Normally, when we do a fasciotomy, a lot of times we'll do more of a lateral aspect to relieve that pressure. The fibula is more the nerve is more of an anterior. Okay, so that's more anterior, and your tibia is more anterior. Okay, so that's going to leave your superficial peroneal nerve, which is more on the lateral aspect. So again, it says we're making a lateral lower leg fasciotomy. The most common liver cancer. The thing to remember about liver cancer is most often liver cancer is never a primary site. Okay. So looking at this, it seems to be hepatocellular carcinoma was what most people chose. And this is actually liver, okay? It's liver cancer, but this is more of a primary. And again, as I said, most often, most common, cancer of the liver is never a primary site. It's always secondary. So that would be metastasis disease. And I think you were looking at this and saying, oh, metastasis disease was way out. All these other ones look like some form of cancer. But hyperplasia, it could not be. I mean, it's just, it could be more of a, does not indicate cancer all the time. Okay. And hemangioma, again, you can have those. Like you may see a hemangioma on someone's face, or you can have it on the liver, a reddened area, but most often those are benign. But again, remember liver cancer, most commonly, if it's detected, it's never the primary site, okay? Which two arteries are preserved during a pancreas retrieval, okay? Now, looking at this, let's see, what was the one that was chose the most? It was gastroduodenal. Okay, gastro is your stomach. Okay, if you look at this little diagram here, here's the gastroduodenal artery. Okay, here's the pancreas, and actually you can see it curves around and it follows the duodenum here. So you can mark that one out. Here we've got gastroduodenal again. Mark it out. So we're left with splenic hepatic and splenic superior. Okay, if we're taking the pancreas here, this is the splenic artery, which you can see it sort of is right here at the pancreas. Okay, and then you've got the coming here. You've got the superior mesentery, which is again right here connected with the pancreas. So if you were preserving those, you must reserve the splenic and the hepatic mesentery vessels. Okay, which is not considered a permanent urinary diversion. Now, a permanent urinary diversion is a ileoconduit. Okay, so if you knew what an ileoconduit was, you would have known that was a permanent urinary diversion. Cutaneous ureterostomy, yes, it's permanent. A ureterocystostomy, yes, permanent. A nephrostomy. We often put in nephrostomy tubes. That's not permanent. It may be that they've got a blockage, but we've got to remove the urine from the kidney so it won't become toxic there. But that is not a permanent urinary diversion. Okay, a patient undergoing a 6-hour debulking tumor here. Let me just see. Most people chose epinephrine on this. Now I've highlighted that the patient is he's having hypotension, which is a low blood pressure, and he's also having tachycardia, which is a fast heart rate. Now, why would you give that patient epinephrine if they're experiencing tachycardia? Because what's it going to do? It's going to increase it more, okay? If the patient's having hypotension, why would you want to give the person morphine? Because it may drop their blood pressure even more, okay? So that's going to leave us with blood products and normal saline. Saline's not going to do anything. Now, if they're hypertensive, if they're low on fluid, they may give them a bolus of saline to get that up. But your blood products are going to be the ones that's going to need to be giving. Again, tachycardia may be a response to the patient that's experiencing hypovolemic, okay? So again, that's a low blood, okay? So this person's hypertension, so they're going to probably get an H&H and determine that they have to give that patient some blood. CBD expiration. Of course, we don't do these much like we used to. Now, if they have stones in the common bowel duct, you're probably, if you've done an ERCP in your endoscopy department, but which is likely to be accidentally injured if we're doing a CBD expiration. If you look at this now, hopefully, all of us have done lots of gallbladders, okay? There is no time when you're doing a gallbladder that you're anywhere near the heart. If you are, then you're in the wrong place, okay? Let me see what was, actually I did have people to choose that, but the most common was between hepatic and cystic. Now remember, the cystic duct and the cystic artery, you're going to ligate those. But I don't know if you can see it here. You've got the hepatic artery, which is running right here posterior. So when you're dissecting and getting into the CBD here, you can actually injure the hepatic artery. Okay, so and also remember on your CBDs, those are the ones that we're going to be using your vasodilators. We're going to put in the T-tube. But as I said, We don't do them that often anymore. I remember the days we used to use the choledystoscope all the time to go in and view the inside of the CBD. Okay, what's concerning a hypophysectomy? Now, your first thing is saying, well, what is that? Okay, we know we're going to remove something because it's got ectomy. But if you remember, that's the pituitary, and this is where you're probably going to have your ENT and your neuro doctor working together. But you should be asking yourself, now, what is the pituitary for? Okay. Um, we should know that it's really has a big responsibility in the growth hormone. So if you knew that, if we would take the pituitary, how would it increase? It would decrease. So we can mark that one out, 3, and then go down below, and we're going to mark out every choice that has 3 in it because we know the pituitary has to do with growth hormones. It would, if we take it, it would decrease it. It wouldn't increase it. So 3, 3, 3. So that leaves us with 1, 2, and 4. Again, this is how you should be approaching these questions and eliminating the ones that you know. Okay, both direct and indirect hernias are the result tears in. Okay, remember the direct hernias are the ones that goes directly through Hasselbeck's triangle. Okay, and a hernia is a ruptured or a tear in mainly the fascia. That's why when you're closing, you want to close the fascia very well, and most often we close it with interrupted. If we would close it with continuous suture, if it breaks, then the whole thing could come loose. Okay. So we know that it should, as I said, the fascia is the main layer. So we want to look at the things with fascia. So that's going to leave us the transversalis, and it's going to leave us with the oblique. Okay. Let's see, what was the biggest answer there? A lot of people put the scarpus layer. Now, if you remember this, you've got the skin, and then the deeper layer with actually in the skin is the scarpus layer. Okay, so again, the transversalis muscle, it has a primary responsibility of the integrity of the abdominal wall. So again, both direct and indirect would be results of tears in that primary role that has to do with the integrity of the abdominal wall. Chalazion, let's see. It was between the conjunctiva and the meibomian gland. So it did have few with a lacrimal and some with an eyelid. Now, chalazion, and this is your, with your ophthalmic, is that little bump there. But what happens is your meibomian glands are not functioning properly. Okay, so you've got some type of blockage, and this is going to cause this little pimple-like thing here. Now it is on the eyelid, okay, but it's not an inflammation of the eyelid, okay. The conjunctiva, that remember that's the mucous membrane that covers the cornea. So this is not on the cornea. And then your lacrimal glands, if you remember, you got the medial canthus here. So we've got our drainage here, okay? And it drains, and if the lacrimal glands are open, then it should be going out through the nose. So this is when we have those pediatric patients that we may bring to the OR and do the lacrimal probing and use the fluorescent inject and see if it's coming out their nose. But it's the meibomian gland. So you got your chalazion gland, excuse me, your number 11 blade, and your little chalazion curette. So it's one of those quickies. Actually, there were sometimes that we actually did in the lump and bump room without any anesthesia. We just do a little local. Wounds that are significant bacteria. Now, the more that I read this, I can see because most of the people did choose. Let me see. Let's see, what was that? Yeah, most people chose delayed primary. Now, the reason that probably granulation would be your better choice is there is significant bacteria and also extensive trauma, or tissue trauma, which may have missing tissue. So we couldn't, bring them back later and do a primary closure because of the missing tissue. Okay, primary union, that would be again the ideal situation, and we wouldn't want to close any contaminated wound. Primary union, and of course, the lag phase. Remember, that's one of the in the first intention. That's one of the three processes. So the best choice would be granulation here. Again, because of the significant bacteria, and based on the possibilities of having some missing tissue because of the excessive trauma. The Navy, let's see, most of you put the carotid triangle. Um, Actually, that is to for the femoral triangle, okay? That's your femoral nerve, femoral artery, femoral vein, and then your lymphatics. The carotid triangle, that's the neck, and that's where the superior part is going to be the digastric muscle, and then lateral, you're going to have the sternocleidoid muscle, and then inferior, you've got another muscle. But the Navy is for your femoral triangle. And of course, I don't know anything about a lumbar triangle. And looking at these two, I mean, both of these, carotid and the neck, sort of go together. Okay, so again, if you're looking at trying to eliminate these two are about the same thing. Of course, we don't do a posterior, but it's still involving carotids and the neck and the. So that would be a way that you could start eliminating. The talus. Now, if you know the talus, it articulates with the tibia. So here's the tibia, and here's the talus. Okay, it doesn't articulate with the fibula. So everyone that has a fibula, you should be able to mark out. So that's going to leave us the calcaneus, the navicular, the tibia, and the calcaneus. I had it twice there. But again, you may have not remembered where the talus was, but it articulates with the tibia, not the fibula. So again, using your process of elimination, you should have been able to eliminate that. Let me see, what was the most? The most choice was the tibia, fibula. So most of them chose this one here, the tibia. All right. Okay. Which nerve can be injured when the legs are improperly flexed? Okay. Now we talked about the perineal nerve here. Okay. This is the one with the candy cane and hitting the side of the stirrup. Okay. The femoral nerve is run here. Okay. Saphenous, of course, is more of a posterior. So it's the obturator nerve. So if you're having, and we're talking about it being flexed here. So if you've got the legs too flexed, it could put pressure on that obturator nerve there. Let me see, what was the one that was mostly chose? Perineal nerve, okay? And remember, that's the one that, as I said, hitting the side of the stirrups. That's why you want to make sure that they're padded real well. And I think most of our surgeons now are using the Allen stirrups. They seem to be pretty well, but there will be times that you will have surgeons that will still want the candy cane or the high stirrups. And again, making sure they're padded and that leg's not resting against that metal bar there, okay? Because if so, then you're going to run the risk of the peroneal nerve being injured. And also, this is important why people shouldn't be resting against the patient's legs as well. Which of the following ligaments direction from the cervix? Okay, let me see. Most people put the round ligaments. Okay, now if you remember the round ligaments are there is right here. So this is where you got your round ligaments, your cardinal, and your urosacral. This is the ligaments that you're taking when you're doing the Haney clamps. Okay. So it is, if you look here, you've got, this is the cervix. So you've got the uterosacral ligaments here going down the inferior direction. So all these, again, would be those ones that you're using with your Haney clamps. Okay, the Lefort fractures. Now, don't get this confused. There's a Lefort procedure that we do in GYN. It's for geriatric patients, and because they're not, they have so many comorbidities that rather than going through surgery, they actually can close the vagina, if the bladder's hanging out, or all those things. But here we're talking about the maxillary fracture that is between the maxillary and the orbital floors. Remember, your maxillary sinuses are right here. You may hear this called the mustache fracture here. Okay, so it would be Lefort 1. Most people put Lefort 3. Now, if you look at Lefort 3, now remember, as these get higher, the fracture gets worse. So look at Lefort 3 here. You've got some major, you've got your orbitals here involved, and we've got to be careful here because remember, we've got the muscles of the eye, and if they're get caught in the fracture, then of course the patient may not be able to move their eyes, and of course there's some nerves. But the one that's running between the maxillary and the orbital floors would be your Lefort 1. Okay, contents of thoracic outlet. Now, I think most or some people look at thoracic and they thought thoracic cavity, because that was one of the ones I could not believe there were so many. Let's see. A lot of it was between A and B, but ascending aorta, you're not. Here's the thoracic outlet. Remember, that's when the clavicle is pushing on these vessels here, okay? So you should have been able to look at this, ascending aorta, superior vena cava, okay, that's the heart, is going to leave you with these two here, okay? And it's actually your subclavian vein and artery and the brachial plexus that runs down, and you can see the subclavian artery and vein right here. But again, I think some people just saw thoracic, thought that that was maybe, concerning the thoracic cavity. But remember, that's the where the clavicle is pressing on those vessels. This one here, the more I read it and went back over it, the more I could understand. And I do want you to go back over that because you may have some wound classifications on here. And remember, the wound classification, the nurse should not assign that to the end of the case, and they actually should be verifying that with the surgeon. Because again, they're not at the wound, and they may not know sometimes that we may nick the bowel and get some spillage. But here we've got a ruptured appendix, and there's no visual bowel contents. So I can see where a lot of people chose the contaminated. I think that was the one that was the highest. Yes, contaminated. And as I said, the more that I went back over it, that's why you were given credit for it. Here, there was no visual. And now, if there was some, spillage about, then of course I would move that to a class 4. The other thing is, don't forget about those 4 hours that lapse, because here we're getting into it can be a little hard to distinguish sometimes. But if you've got a question and it says that it was over 4 hours, you got a contaminated wound, then it's going to move to a dirty infected. But again, at the end of the case, and it should be verified with our surgeon. All the following are true with the hematocrit. Let me see, what was the, it seemed like the last one was the most choice. Okay, remember that the hematocrit is going to be a little different from men and women. Men, you may see like 40 to 54, and then women is, I've actually seen it went up to 48, 36. So on your national exam, they're not going to give you choices that are so close that you're going to be struggling to decide which one, okay? So hematocrit, okay, we know that is with the RBCs, okay, and the normal value for a woman is 37 to 43, okay, that would be good. Hematocrit is the value of RBCs expressed in the number of cells per cubic millimeter. Okay, you need to ask yourself, okay, here's a hematocrit value right here. Is that expressed in a per cubic millimeter? No, it's as a ratio or percentage, okay? So you should be able to mark that one out. Is that supposed to be? Okay, a decrease in the hematocrit indicates a decrease in the RBCs, okay? That's true. We're looking for all of them true, except which one's going to be false, okay? And hematocrit readings are unreliable, and they are. You're going to have to wait. They will wait several hours if they transfuse a patient before getting the H&H, because it's going to be a false read, okay? But again, it's not expressed as a cubic millimeter. That's the one that's false. All the rest of these are right. Okay, this is the last one, and I highlighted neoplasm that has not, okay? If you don't remember what in situ means, it means it's localized, okay? It hasn't spread. So if you hear them say the tumor was in situ, then that's good because it hasn't spread. So extended, that means it's went beyond. So not good. Spread, the same thing. Excuse me. It has not extended, okay? Spread, it's went beyond. So invaded, it's invaded the nearby tissue. Metastasized, we know that that's moved to adjacent tissue. So in situ, again, means that it's localized and it has not extended beyond the membrane. So you got to read these very careful because it's very easily to mix them up. So I hope you found this helpful. The main thing is try to learn that elimination process. Again, with high stake testings, you're able to almost always eliminate 2, and then you've got to narrow it down.